Hi, I'm Lauren Henke, and you're listening to another episode of the NRG Oncology Podcast with my co-host, Stephen Chun. Today, Stephen and I are joined by someone who almost needs no introduction in NRG Oncology circles. Dr. Norman Wolmark is one of the 3 cooperative group chairs for NRG Oncology and is a professor of surgery at the University of Pittsburgh. He's spent decades advancing surgical oncology, particularly for women with breast cancer, through his involvement with the legacy NSABP group and then now through NRG Oncology.
Dr. Wolmark, before we get into the history of the NSABP and the advances in surgery we've seen through the cooperative groups, I wanted to start off with something that is affecting everyone at NRG right now. And I wanted to ask, what is behind the recent push for financial austerity and frugality at NRG? I've noticed, the food is much more simple. The audiovisual equipment is kind of being phased out for some of our committees to try to save on the budget. And how is doing more with less affecting our operations?
Well, it's interesting out of all the topics that we could have chosen and the stellar history of NRG and its predecessors, that the first item that selected to discuss is a period of austerity and belt tightening. It's not unique to NRG. All the cooperative groups are having challenges with the budget. The budget has never been able to cover the scope and the requirements of the cooperative groups. The budget, as you know, has a fixed corpus, and we don't have a lot of leeway in augmenting one aspect and moving the funds from another. But you mentioned the meeting and the availability of refreshments and food and so on and so forth. Why the cutbacks? Well, if we had our way and if funds were unlimited, we'd have as much food and support and refreshments as anyone could want. But that's not the case. When we did an analysis of where we were losing money, it became clear that we were losing at least $200,000 per meeting, and that's simply unsustainable. So it's not that we want to make the meetings less enjoyable. On the contrary, from a financial standpoint, it simply did not make sense for us to continue those significant losses. We also analyzed why the costs were going up, and of course, the pandemic led to remote meetings, which reflexly one would think would decrease the costs. In actuality, because of the audiovisual requirements, the interactive components, the multiple concurrent meetings that NRG had, the costs became cumulative. And it reached the point where we had to intervene. The other groups were facing the same problems. One group is going to only one meeting per year, having the other meeting as virtual. But I think having a decreased number of concurrent sessions with the audiovisual support being eliminated, I think will lead to substantial cost savings. We have many of the non-principal, and I don't say that pejoratively, sessions that are virtual, preceding the meeting or following the meeting. In this way, we hope that we can cut the deficit incurred by these meetings, so that we would have sufficient funds to continue our mandate. So I hope that that gave you a perspective as to what's going on, in particular relative to the austerity relative to the meetings.
I think that's really nice context and helps people to understand perhaps that there's nuanced decision making going into this. I think many of us hear frequently about budget cuts or potential budget cuts for cancer research and NCI efforts. And I think perhaps there's a lot of people out there also who don't realize the degree to which organizations like NRG Oncology function because of really massive amounts of volunteer work. Like Stephen and I, of course, do these podcasts as volunteer effort, and Stephen even hit up his friend, John Kimura Parker, to get free theme music for the podcast. And I'm wondering, could you speak perhaps to the American taxpayer out there on just how much of our operation really does depend on volunteerism, and whether or not you think they might be getting a good bargain for their money with NRG Oncology?
I think doing clinical trials in the manner that we do clinical trials, randomized prospective clinical trials, cannot be done without volunteerism. Anyone who approaches clinical trials with a business plan to break even, I think, is not the kind of person who is passionate about clinical trials. I have always, throughout my career, been absolutely amazed at the selflessness of individuals who are involved in clinical trials, who give up their time, give up part of their salary, give up RVUs to be involved in doing clinical trials. This isn't an issue of recapturing lost revenue. This is an endeavor of passion, of engagement that's catalyzed by the belief that one is doing something that's noble. And who can argue with that cause? Allaying suffering, prolonging survival, I think is an absolutely noble cause. And I am so grateful to those people who join us in this quest in sacrificing their own immediate gains for future advances. That's what clinical trials are about. We'd like to pay everybody for their time, but as we pointed out, our corpus is limited. And if we want to focus on our specific aims and our overall goal, we know that there are areas that are going to be underfunded or unfunded.
Sometimes I think it's funny. As academic physicians, we think of ourselves maybe as, the smartest ones in our college or medical school classes, but it really makes you wonder how smart we really are, the amount of effort and volunteer work we put into this stuff, basically for free. I think there's very few other, industries or fields where, people just, do an enormous amount of work for free. And that's really what NRG oncology is about. It's as you described, volunteerism to try to make people's lives better. And so, really, the last question I want to ask on the topic of the financials and frugality and austerity at NRG oncology, I want to ask, what do you say to people out there who want to cut the budget of the National Cancer Institute, especially as it pertains to the cooperative groups?
Well, I think that would be a huge strategic error. I think that to use a colloquialism, the bang for the buck that we get out of the cooperative group clinical trials is enormous. I mean, I won't give percentages, but for every dollar that's allocated to the cooperative group mechanism, the amount that covers is a fraction of the actual costs. And that's been a problem ever since the cooperative groups were initiated. It has been underfunded continuously. And that's waxed and waned. And of course, I think we're going to wax forward. We've been there before. It's a cyclical phenomenon. And I think we have to do whatever we can to overcome these deficits. we've lived with them as part and parcel of our being and the essence of doing clinical trials. They are significantly underfunded. I think there's no argument from the NCI. The money simply isn't there to cover the costs. We have written white paper after white paper, we being the cooperative group chairs, pointing that out, providing actual data and numbers to support that observation. I think it's a truism, not only an observation. And it's not going to be resolved. It will be significantly exacerbated by significant budget cuts. I think we're working with the bare minimum as it is.
The amount of volunteerism and just the hundreds, thousands maybe of people, and certainly over the years, who have dedicated their time and efforts to NRG Oncology just shows the strength of the mission. And I agree with you that this is just such an important enterprise for healthcare and for allaying human suffering, as you pointed out.
The altruism that exists out there is incredible. Every time that I see it, I am in awe of the members that make NRG what it is.
Yeah, I'm almost, stunned when I hear, people talk about the cooperative groups and the NCI as wasteful government spending. It just, I think, it's an extraordinary bargain, for, fairly little money. You have a huge group of people doing an enormous amount of volunteer work. I mean, when could you ever, put, a little money to organize people and have a bunch of highly trained people get together to devote hours and hours of time voluntarily? I mean, it's really something if you think about it.
It is one of the best bargains that we have in scientific research. It has always differentiated us, particularly the United States, which has government funding for clinical trials, compared to other initiatives. I think that differentiated us, that made us unique. To undermine that process, I think is short-sighted. And I think the people who are going to pay the price are our patients with cancer.
Another topic that Stephen and I really wanted to explore with you is some of the evolution of NRG oncology. For those in our audience unfamiliar with the history or who've maybe forgotten, the N part of NRG oncology originated with the NSABP, meaning the National Surgical Adjuvant Bowel Project, which merged with the RTOG and GOG a decade ago to form NRG. Dr. Wolmark, what was the NSABP? What was it like, and how is it integrated into the DNA, if you will, of NRG oncology today?
Well, it's an integral part of the DNA of NRG oncology, and I have to pay homage as the contact PI that was part of this process from the beginning. We were created and funded in 2014. I have to pay my respects to the other two founding chairs, Wally Curran, who stepped down at the end of 2020, and Phil Desai, who was succeeded by Robert Mannel in 2017. Without these two giants, we couldn't have achieved what we have achieved. I mean, taking three heterogeneous groups and forming one cooperative group, giving up the isolationist mentality for the overall good of the group, I think is a remarkable and dramatic success story. The NSABP was, as you pointed out, the National Surgical Adjuvant Breast and Bowel Project was one of the founding members. And I think it has a long and storied history that really recapitulates the history of the cooperative groups. we were founded and created by the National Institutes of Health in 1958 or thereabouts. We were even named by the National Institutes of Health. We never would have picked a name as uneuphonious as the NSABP for ourselves, and that came out of an initiative from the NCI of the National Surgical Adjuvant Projects for solid tumor in the late 50s for gastric, for lung, for colon, and so on. And the NSABP is the only remaining group from this era. And I think it does recapitulate the entire history of the NCI evolution of the cooperative group process. I don't know if we want to get into the accomplishments at this point, or go on with your questions. You let me know.
Well, happy to go on to accomplishments, which are many, and yeah, if you could touch a little on your accomplishments with the NSABP, but also, I feel like every time there's something that comes up from the NSABP or its work through NRG Oncology in terms of accomplishments, Bernie Fisher comes up and gets credit and a good review. Who was Bernie Fisher? And
Yeah,
why?
and I think that credit is certainly well deserved. You know, Bernie Fisher became chairman of the NSABP in 1967 when the NSABP was still at Roswell Park, and then moved the NSABP to Pittsburgh in 1970, where it's been ever since. Steve, I think we owe Bernie an enormous debt of gratitude. He instilled us with a passion for the randomized prospective clinical trial. He convinced so many clinicians that it represented the opportunity to establish the standard of care using the scientific method. Just as importantly, it delivered us from the age of tyranny, the age of authoritarianism, when an individual could ascend to the professorial pulpit aimed with a retrospective anecdotal case series and dictate the way a tumor is treated for the better part of a century. And that's exactly what happened in breast cancer. The effort that it took to overcome the yoke of William Stewart Halsted was enormous. What differentiated Bernie was that he wasn't interested in participating in more polemics, debating on whether or not we ought to do radical operations. And it's not just isolated to breast. The whole concept of radical en bloc dissection is common to solid tumors in general, head and neck, melanoma, pelvic cancers. And Bernie challenged that and challenged it in an environment that was absolutely hostile and acrimonious. I think if we were to ascribe the one important contribution, or the most important contribution that Bernie made, was that he mainstreamed clinical trials. We now say, well, what are the data from randomized prospective trials before I'm willing to change the standard of care? That's all due to Bernie and the early days of the cooperative group process, when the randomized trial in many instances was vilified. Cushman-Higginson, for example, who was the most authoritative figure in 1973 when I came on the scene, when I joined Bernie Fisher, lashed out in an editorial in JAMA saying that what we were doing, what the NSABP was doing, was a giant leap backwards. And he challenged the validity of the randomized trial. And it wasn't just Hagenson. Hagenson was representing mainstream thought and mainstream concept. And to overcome that, I think, is an enormous contribution. And I think Bernie was an integral leader in doing that.
That's an amazing history. You've been quite modest about your own role in all of this. So I'd like to ask you, if you could choose one thing, what do you see as your biggest contribution, or perhaps a contribution you're just the most proud of to the NCI cooperative groups over the years?
Well, I think my greatest contribution is counterintuitive. I mean, it's been quite an evolution and quite a story of clinical trials. The retreat from radical mastectomy, total mastectomy, lumpectomy, to sentinel node, to the retreat from radiotherapy to the ipsilateral breast, the extent of operation. We did the indication trial for adjuvant tamoxifen. We introduced neoadjuvant chemotherapy in 1988, the first trial, randomized trials done of preoperative versus postoperative treatment, and a whole series of trials. We developed the Oncotype DX to retreat from treating everybody who was ER positive with chemotherapy. Landmark contributions, trastuzumab, and early breast cancer that we reported at an emotional ASCO educational session in 2005. We did practice-changing studies in DCIS, and two prevention trials that had over 13,000 and close to 20,000 patients respectively for tamoxifen and raloxifene. So there's certainly a stellar history there of contributions that changed the standard of care. But the thing that I would view as my most significant contribution was rescuing the NSABP in 1994. You may or may not know, and perhaps you prefer not to know, that in 1994 we were the focus of a congressional subcommittee investigation, Energy and Commerce, where the NSABP was nearly placed into extinction. And it was a result of one investigator in Montreal who had submitted fabricated data on our lumpectomy trial. And it shut us down and launched investigation after investigation. When all was said and done, there were 6 patients out of over 2,000 who were disqualified because of inaccurate data. So be that as it may, I think we were able in 1994 to pick up the pieces so that the NSABP could continue and fight again and continue with our clinical trial mandate, the 25-year update of our total mastectomy trial B04, the 20-year update of our lumpectomy trial, the sentinel node trials, and so on and so forth, the trials that we talked about previously. So I view that as my most significant contribution. We can pick some of the others, but I think from an overall perspective, to be able to continue with our mandate of challenging the status quo. That's what we in NRG are all about. Challenge the dogma that currently exists, challenge the biases as we brace ourselves for another era of anecdotalism, which seems to be inevitable, and we have to overcome that. So I think to have been able to continue the NSABP and subsequently lead to NRG is something of which I am proud.
So, on this note, you have obviously been involved with cooperative groups, NSABP, NRG for a long time. You've seen enormous changes like you've just described. And I want to turn to the great philosopher Bob Dylan. He's got the song, "The Times They Are A-Changing." If I might quote the song, he says, "You better start swimming or you'll sink like a stone." And as the present now will later be past, as someone who I think has seen it all, how must NRG continue to evolve over the next 5 to 10 years? And what changes do you think need to happen to keep up with the times, especially because you are the contact PI for the NCI grant?
Well, certainly I'm a fan of the Nobel laureate in literature that you just cited, Bob Dylan. What he said was not original. You can quote Alfred Lord Tennyson a century earlier, 1860. The old order changeth as it must, leading to new. Change is inevitable. I mean, we have to embrace change. It's not voluntary. Nobody's going to ask us. We either embrace it or become pedestrian, or become an anachronism in our own time. We have seen, cataclysmic changes. Certainly in my career, we'll continue to see them. You asked me to predict what changes we have to make. I don't have that kind of sagacity to be able to tell you how we're going to have to respond to changes of which we are not aware. We have to be prepared. We can't be dogmatic. I think we're going to be in for an interesting ride. I think we're going to have to strap in and respond accordingly, whatever the vectors are that are going to face us, and I think they're going to be many. I can't predict how they're going to play out or what action we are going to take to address them, but whatever the necessity is, we are going to act on. So, will clinical trials remain relevant? Will the cooperative groups remain relevant? I think absolutely they will. Will we have a difficult time? I think we will as well. Will we overcome it? I'm confident we will. And, I'm at the denouement of my career. And, thank goodness I can pass the baton to young and vibrant investigators. It's been a privilege to work with Quinn Lee and Robert Mannel. I mean, this was, a gift for me in my latter years, for which I am grateful. But whatever the challenges and requirements that are imposed on us, I'm confident that we will rise to the occasion.
Lastly, I want to ask something that we're asking all three of the NRG Oncology Group Chairs. With the NRG NCI grant submission coming up, and with your lead role, can you share with us the major aims and goals that might be relevant, particularly to surgical oncology and maybe even the grant strategy as a whole?
Well, we're a unique group in that our concentration is on local regional aspects of cancer. We're the only group that has a gynecology focus at such a major part. We're the only group that has the radiotherapeutic focus, and in that way, we're unique. I mean, what are we going to do vis-a-vis surgical oncology? I think that the scope of surgical oncology in many ways has been stereotyped. You as a surgeon, for example, and I've heard this time and time again, should be concentrating on studying, whether margins ought to be 3 millimeters, 2 millimeters, or 1 millimeter, how many lymph nodes to remove, what the extent of the dissection ought to be. That's not my concept of surgical oncology, and it hasn't been the concept of NRG's overview of surgical oncology. It's a continuum. It's an absolute continuum. The retreat from radical mastectomy is inextricably intertwined with the ascent of systemic therapy. And as surgeons, we did both as part of the continuum. As radiotherapists, they were integrally involved in the evolution of therapy. The retreat from local regional therapy, the ascent of systemic therapy leading to targeted therapy with Herceptin leading to the checkpoint inhibitors is a continuum. It's a continuum that was evolved by surgeons, radiotherapists, medical oncologists, and gynecologists in unison. And I think that's what differentiates us. I think that's what makes us who we are, and that's going to put us in good stead for the future.
Well, Dr. Wolmark, I just wanted to say again how much of a pleasure it is to have you. It's always a thrill to hear directly from one of our cooperative group chairs. For those of us, who are young, as you say, we really look up to all of the work that all of you have done through these storied careers, and we hope that we are passing the torch to make patients' lives better.
I
So,
think that's a great point, Steve, that I think we would be remiss in not emphasizing. We passed the baton. I mean, we're the present, the past, the future is in the young, outstretched arms who are waiting for that baton. And I exhort you. I mean, go forth, do better than we. We'll rejoice in your glory. It is an important and noble effort, and I would urge all the young investigators, and I call them young investigators, not medical oncologists or surgical oncologists or radiotherapists, to pursue clinical trials with passion. It's well worthwhile.
well, again, for all of you tuning in, we had Dr. Norman Wolmark, who is the one of our cooperative group chairs for NRG, and he's spoken to us about the origins of NRG from the NSABP, which he has been the chair of the legacy group. The NRG Oncology Group is supported by grant funding from the National Cancer Institute, and content of this podcast does not necessarily represent that of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.